Bismillah ar-Rahman ar-Rahim. I wish to thank all of you for attending this very important session, and I wish to thank Professor Hassan Abu Alfa to be with us from New York, USA, virtually. And it is my pleasure to welcome all of you. Today we are talking a very important point about hepatocellular carcinoma, immunotherapy, new medications, and new hope. All of us know that hepatocellular carcinoma is a challenging tumor with high incidence and high mortality rate. Unfortunately, in Egypt, we have a very high incidence with hepatocellular carcinoma, and it is well known that hepatocellular carcinoma nowadays is the most common malignancy in Egypt, whether in males or all genders. Of course, for females, the breast cancer is the first malignancy. But what is more important that if you look here to the new cases of liver malignancy, you will notice that the new cases is about 27,000, while the estimated number of mortality is nearly the same. It is 26,000. So we are losing most of our patients during 1 year. If you go here for breast cancer, you will notice that the breast cancer 22,000 per year, but the mortality is only 9,000. So we are dealing with a very high prevalence, incidence, and high mortality. This is why we have to work in this. The most common cause of hepatocellular carcinoma in Egypt is due to hepatitis C virus. This is all the studies. The HCV antibody is present in more than 90% of our cases of hepatocellular carcinoma. Of course, the National Committee for Control of Viral Hepatitis started the HCV elimination since 2006 until we have the direct antiviral agents, and we were able to treat more than 4 million Egyptians with hepatocellular carcinoma during the last 4 years. And in October 2019, we started the presidential initiatives for screening of more than 60 million citizens to discover those who have HCV and to start to treat them. The screening and treatment program to eliminate HCV in Egypt was published in 2020 in New England Journal of Medicine, and here is the data that it drops to 5% at that time, but fortunately, nowadays the prevalence of HCV PCR in Egypt is less than 1%. But still we are facing a big problem because after treatment of HCV, those who have liver cirrhosis due to HCV still have a risk of development of hepatocellular carcinoma. And this risk for development of hepatocellular carcinoma range between 2 to 8%. And also, if anyone develops hepatocellular carcinoma, the cumulative recurrence is about 70% over 5 years. All of us know the modified Barcelona Clinic for liver cancer staging, and we know that if you have bad liver functions, so you are stage D, if this patient can do liver transplant, this is the best thing for him. But for even those with good liver functions, this depends on the number, the size, and the spread of hepatocellular carcinoma. And we can notice that if you discover the lesion very early, less than 2 centimeters, the survival is more than 5 years. But if you discover the lesion lately with some portal vein invasion or extrahepatic spread like lymph nodes on the abdomen, the survival is about 10 months. So this stage where we have to use the systemic therapy, we need a lot of development in this treatment to maximize the benefit of these drugs to increase the survival. Of course, at the same time, we want to increase the screening and surveillance for early development or for early discovery of HCC. And this is what we are doing now on the National Committee for Control of Viral Hepatitis. We have a screening and treatment program related to the National Committee for Control of Viral Hepatitis. And the manager of this program is Dr. Muhammad Abdullah Abdulaziz. And during this program, we offer screening and surveillance for all our patients who have been treated for HCV and those who have liver cirrhosis. We are making for them ultrasound and alpha-fetoprotein every 4 months. Suspected cases with elevation of alpha-fetoprotein or with any focal lesions on the liver, they are referred to specialized center for dynamic imaging studies, and they are, if proved to have hepatocellular carcinoma, they are referred to multidisciplinary team for management of these cases of hepatocellular carcinoma. Till now, we have 75 surveillance centers applying the alpha-fetoprotein and ultrasound for our patients. We have 63 centers to refer patients to do dynamic or triphasic CT, and 30 centers to do dynamic MRI for our patients. And we have 22 multidisciplinary teams to evaluate patients with hepatocellular carcinoma, and we are preparing new 8 centers for tumor board for hepatocellular carcinoma. We recruited about 111,000 patients, cirrhotic patients, to look for them for focal lesions or elevation of alpha-fetoprotein. And we referred about 3,700 to do CT or MRI. And by CT and MRI, we proved hepatocellular carcinoma in 1,400 cases. And from these cases, 1,100 cases referred for the tumor boards. And we started systemic therapy program beside the other treatment modality. And this is started on January 20th in 2022. And we used till now sorafenib and regorafenib, and they are available in our centers. And we have the protocol for systemic therapy for these patients. Systemic therapy program for HCC, the program provides treatment, care kit, follow-up investigation for free for all our patients. Until today, more than 1,000 patients started therapy. Of course, some of these patients are not coming from the screening, but patients who received or diagnosed to have hepatocellular carcinoma and candidate for systemic therapy, they were referred to our centers. And this is the cases, the rising curve of the cases starting from January till June for using of systemic therapy. I will stop here and ask Professor Ghassan Abu Alfa to talk about the immunotherapy, the new hope for our patients. And it is my pleasure to introduce Professor Ghassan Abu Alfa. He is Professor of Gastrointestinal Oncology, Memorial Center for Cancer in New York, and he is the chair of the National Cancer Institute Hepatobiliary Task Forces, and he is the president of the International Society of GI Oncology. He has more than 220 publications, 75 of this publication on the field of hepatocellular carcinoma, and his H index is 45, and it is our pleasure to hear from Professor Ghassan Abu Alfa about the revolution on immunotherapy. And during his talk, there will be discussion from the panelists, and Dr. Walid Abdelati, Professor of Tropical Medicine and Hepatogastroenterology from Ain Shams University, will lead this discussion. And thank you very much, Professor Ghassan. It is the floor for you. Thank you very much.
Good afternoon. Assalamu alaikum, everybody. And thanks so much, Dr. Jamal. And it would have been very nice to see you all in person, but we hopefully, inshallah, will make the best out of it during this virtual meeting. So I'm going to go ahead and share my screen. And as we pretty much heard already from Dr. Asmat, this is a very evolving field and critically important for Egypt because, unfortunately, of the continued presence of hepatocellular carcinoma with a high incidence in Egypt. So I'll be talking exactly as requested and suggested by Dr. Jamal on the immunotherapy in unresectable HCC. These are my contacts, and please feel free. You can take a picture of the QR code. You can also copy whatever you like. The organizers also have my information, and you're more than welcome to reach at any time. More than happy, as many of you know, to contact and respond to any academic and educational question, or of course even research questions. Always happy to work with all of you as all of you've done. So with this said, we're going to jump on right away to the subject matter. We all are very well aware of the SHARP trial, sorafenib, which you might recall proudly we actually launched in Egypt in the Alexandria Library almost like 15 years ago. And we did depend on that data quite a bit because of median survival of 10.7 months for sorafenib versus placebo 7.9 months. Clinically and statistically significant. And this became the standard of care. This is what we did depend on, and this is what we have been using since, albeit that we were very concerned about certain side effects, adverse events, and of course, not necessarily that it was up to the aspiration and satisfaction in regard to survival. We all wanted more than the 10 months per se, but at least it was a good start move in regard to a disease where there was no therapy before that could be of benefit. After sorafenib, we tried hard, we tried very hard, and collaboratively worldwide, we tried in different directions, and we could not get to anything until lenvatinib came into play. Lenvatinib, as we all know, is another tyrosine kinase inhibitor. Dr. Kudo, wisely and smartly, however, argued that you will not necessarily look for superiority to sorafenib, but look for non-inferiority. In other words, can we prove that lenvatinib and sorafenib are as good as each other? And the study was positive. The overall survival was similar, 13 months or so between the two arms. I'm showing, though, here the progression-free survival because despite, and this is how I would like to always think about it, think of the survival as being a racetrack. It has a certain length, that's it. There's only kind of like racetrack that you can run on or have a car run on, and this is where survival is. However, can you have a faster car on the racetrack? Of course you can. And this is the argument that was given for lenvatinib, because as we can see, the progression-free survival was almost twice higher than lenvatinib compared to sorafenib, showing us that, yes, despite that the same survival, at least it has more potency in regard to response, and of course, with an improvement in progression-free survival. However, still we were not necessarily fully satisfied. No doubt 12, 13 months is a good thing, but we came in to the advent of immunotherapy. Immunotherapy has a long story in regard to HCC. It started more than a decade ago. We're proudly here at Memorial Sloan Kettering Cancer Center. We were the first to start looking into it and dissecting some early looks that were done in Spain. And if anything, other groups and teams have worked very hardly on. Enough that one reference point has been the AMBRAVE 150 of combination of atezolizumab plus bevacizumab that were compared to sorafenib and showed a rather quite intriguing and a new number for us, 19.2 months survival for atezolizumab plus bevacizumab compared to sorafenib 13.4 months. We were very delighted to hear this. As we all know, with a positive study, you get a lot of questions as well. And there were some questions that really did not yet pan out in regard to the AMBRAVE 150, among which you recall, and please, I urge everybody, if you decide to use atezolizumab plus bevacizumab, make sure you do endoscopy because bleeding from varices can occur. Number two, the issue of anti-drug antibody that occur about 30% of patients, which make it ineffective in 30% of the patient. And of course, who are the patients, which we'll talk about a little bit later on. However, more importantly than this is really what is dependent on. How did we come up with those results? Well, this is a very depictive and well-known cell cycle graphic that, if anything, tells us exactly what we're trying to do here in regard to immunotherapy. As you can see at point number 7 at the bottom of the screen, this is where PD-1, PD-L1 activity does occur. Simply, you can think about it as being like when the cancer grows, it kind of pick up the phone and talk to the immune system and say, well, we're here, we're not gonna bother you, please don't bother us, let's just be friends. And as a gesture, the cancer cells will provide some seats or some chairs right on the membrane. Enough those immune cells will just sit on those chairs and never touch the cancer cell. And that's why immunotherapy has been at least thought of since the 60s, but never worked in that disease or any disease. And ultimately, we knew very well, and this is where anti-PD-1 and anti-PD-L1 are, because what these drugs do, they kick out the chair enough that now the T cells can fall onto the cancer cell membrane and cause their effect to kill the cancer as an immune activity. Interestingly, we tried to do immunotherapy as anti-PD-1, anti-PD-L1 by itself, but it did not work. We know very well it's as good as sorafenib. I'll show you more data on that in a second. But more importantly, we figured out that ultimately, to get really the best effect for that activity, you need to kind of get a certain command from higher in the chain of command to tell the anti-PD-1, anti-PD-L1 to do their job, kicking the chair out so the immune cell can fall to the cell membrane. Interestingly, as you can see on point number 5 on that cycle of the immune system, you'll see VEGF. This is exactly where AMBRAVE 150 works. This is where atezolizumab plus bevacizumab work. Atezolizumab is sitting right at the cell membrane at point number 7, and the anti-VEGF of bevacizumab is right there on point number 5. As you can imagine, you can use many things. I always would like to think of the immune therapy as being a scaffold. It's like the brace of a building. And now what you're going to dress the building with as walls and paints, this is really what you add on to the immunotherapy. And as you can imagine, the best dressing will come all the way from the top of the chain of command, which is point number 3, which is the lymph node itself. Because all those requirements, ultimately, they start in our lymph nodes, like in our neck or wherever it is. And if anything, this is where CTLA4 sits. And if we can control CTLA4, we then, of course, have command over the anti-PD-1, anti-PD-L1 activity. So how did we decide to do that? This is where the Himalaya study came into play. And on behalf of all colleagues, I'm very proud and honored to have presented and present to you again the phase 3 study results of this open-label, multi-center study of tremelimumab plus durvalumab as first-line therapy in RCW HCC. This, by the way, was presented originally at GI ASCO in San Francisco back in January this year. And we proudly just published it literally a few weeks ago in New England Journal of Medicine Evidence. These are the results. And you might recall, so those who attended GI ASCO, I started by showing you the results first. Because after all, we're very proud of the outcome, and same time to really show what it means so we can dissect it a little bit and analyze it further. As you can see, combination of tremelimumab plus durvalumab, anti-CTLA4 plus anti-PD-L1, improvement survival up to 16.4 months versus sorafenib 13.8 months, same like what we have seen in other studies. But clearly we have an improved survival here for the durvalumab plus tremelimumab, 16.4 months, clinically and statistically significant. I would like here to note, very important, that the dose of tremelimumab was only one dose only. Can you imagine, like, we don't really do that much in oncology where you give only one treatment once in a lifetime of patient and still benefit from it. Let's look into this a little bit more details. So what's going on exactly? I already showed you some pictures, and now we're looking a little bit in more details. If you can remember, we have on the tumor cell, we said PD-L1. We spoke about that. Remember the chair and how the T cells can fall onto it. On the other hand, all the way in the lymph node, which is in the center of the screen and the purple color or pink color, you'll see CTLA4 kind of like connecting with the antigen-presenting cell. And there's certain activation that occur at the level of CD80 and 86 that will kind of like enhance that anti-tumor T cell to send the command to the tumor cell itself and link in with the PD-L1 to cause the effect of the anti-cancer activity. This is what appears to be very complex. If anything, I would really add on here the drugs. You can see tremelimumab will be the anti-CTLA4, and you said we do it only once. And at the same time, this now kind of like will really enhance the stimulation enough that PD-L1 activity can cause its effect. Durvalumab come into play at the tumor level and will do the inhibition of the anti-PD-L1. But as we said, will not be able to do that effectively or super efficiently except with the presence of the tremelimumab activity beforehand. The design of the study was evolving over time. We wanted to really look at the T300 plus D, which is the main comparison versus sorafenib for improvement in survival, for superiority. On the other hand, we wanted to check on durvalumab, a single agent anti-PD-L1 versus sorafenib. But based on what we know already and what we have known from other drugs, we wanted to look for non-inferiority. Is really durvalumab is as good as sorafenib? And you can imagine why it is important, because there could be other ramifications, got to adverse events, etc. And lastly, there was another arm that looked into 4 doses of tremelimumab at lower dose, 75 milligram times 4 every 4 weeks, But this ultimately was discontinued from the study because, if you recall, on the prior phase 2 trial that we proudly already published in JCO, the called AC22 study, the T75 plus D was not really any different from durvalumab single agent. And as such, we decided to cancel that arm from the Himalaya study and we end up only with the 3 arms. Again, T300 plus D, looking for tremelimumab single dose plus durvalumab versus sorafenib, looking for superiority of overall survival. You can see it in blue to the extreme right. Durvalumab versus sorafenib, looking for non-inferiority, which you can see in the green to the right as well. This effort was open for all patients with HCC worldwide and independent of what etiology it is. But of course, we stratified based on macrovascular invasion, etiology, and performance status. And the study ultimately accrued 1,324 patients, the largest study ever done for liver cancer in the world. I would like to reiterate one more time exactly what happened in regard to how CTLA-4 do its job. Interestingly, as we already mentioned, CD28 kind of like is, pretty good friend. So it convinces CD80 and 86, and they can drink like probably some very strong coffee together. And this way activate CD80 and 6 to send their message all the way to the cell membrane where anti-PD-1 is doing its job so it can cause the combined effect. Interestingly, CTLA-4 come into play and convince CD86. I don't know what they do together, but they fall asleep altogether and ultimately they don't do their job. This is where anti-CTLA-4 come into play. Anti-CTLA-4 will pull away CTLA-4, letting CD86 do their activity again with the influence of CD28. And that's really how it happens. And if anything, what I'm showing over here, by the way, and those simplistic terms, this is what actually got the Nobel Prize for medicine back in 2019 by Jim Allison and colleagues for the work that he did here at Sloan Kettering before he moved out of Sloan Kettering. Interestingly, another important point, and I'm showing it here with a picture of a jumping start of a car battery, because this is how we all do it. When our battery in the car breaks, we try to jump start it with power from outside. And I want you to really think about the anti-CTLA-4 of tremelimumab exactly as a jump starter, because you really kick in the engine and then you drive with durvalumab as pushing on the gas with durvalumab. But why I'm showing this over here, there's a very important finding. Anti-CTLA-4 of tremelimumab is 3 times more potent than CD28. Wow. Imagine that a drug is more potent than the natural phenomenon itself. And one more argument why one dose is more than needed for tremelimumab. So let's go back to the study, dissect a little bit details and analyze the outcome. The study was, of course, equilibrated very well in regard to the demographics. Understandably, which has always happened, there was more men into the study causes liver cancer. Median age is a standard 65 years of age. The presence of patients was about 40% or so from Asia other than Japan, which is really important because this is where Hep B is. But at the same time, rest of the world, including Japan, where Hep C and NASH are. And as you can see, it was a very robust distribution of the patients, 30% Hep B, 30% Hep C, and 40% non-viral, which is a very good comparator to the true current situation that we see worldwide in regard to the disease. Performance status, as we can see, was appropriate 2/3 0 ECOG and 1/3 1. BCLC that Dr. Jamal was just talking about, we have about 80+% with BCLCC. All of them were Child-Pugh score A. ALBI score, which we're still evolving with and to learn it more, but about 50-50 between ALBI 1 and 2. Microvascular invasion about 25%. Extrahepatic spread 50%. PD-1 activity and the AFP level were there about 40%, but to be fair, we don't know what it means. We are really not sure if it means anything, but nonetheless, we did collect it for at least making sure we have complete analysis. I would like here, and not in the aim of comparison, but it's very important to put a mindset, because when we come to survival, it's very understand and remember that, as you can see in the Ambrave 150, there was a very strong presence of hepatitis B patients, 50%. So it was really mainly driven by Hep B patients, with only Hep C 20% and non-viral 30%. Remember, 30 for Hep B, Hep C, and 40 for non-viral for the Himalaya. And here, 50 for the Hep B, 20 for the Hep C, and about 30 for the non-viral. We'll come to a little bit of analysis of this a little bit later on. So, what happened, to go back to our Himalaya study, what happened to those patients who got second line? There's always a question that we all ask. Understandably, for the patient with sorafenib, of course, they try to get other targeted therapy and sometimes even immunotherapy, as we can see 17% did so. In regard to, however, for the T3 plus D plus durvalumab and for the VARB arm, of course, they went for targeted therapy like lenvatinib, for example, as you can see, about 40% of patients or so. One more time, I'm showing the same results I showed a little bit in the beginning, which is the overall survival data. But I'm starting this time with the durvalumab versus sorafenib, which you recall I said it's going to be non-inferiority, 16.6 months for durvalumab, 13.8 months for sorafenib. As you can see, the two curves hug each other extremely well, even though there is a certain separation that starts at the tail of the curve. This is how the priming of the T cells takes time until it happens. We can see at 18 months, certain separation, but ultimately by 36 months, about 25% of the patients on durvalumab were still alive. On the other hand, the T300 plus D versus sorafenib shows 16.4 months versus 13.8. Again, one more time, the median is clearly statistically and clinically significant. But as we can see one more time, we start seeing separation of the curve. Probably we kind of, estimated it and calculated about 9 months or so. As you can see, the hazard ratio jumped on to 0.7 after 9 months. And there's a continued separation between the two curves, enough by 3 years. Whoa, we never really had this number. 3 years, 1/3 of the patients, 30% are still alive. I would like here to make a very important note. Please, I urge you, the number that we just showed for durvalumab alone versus sorafenib, showing 16 versus 13.8, is not the same 16.4 here versus 13.8, because the calculations are totally different. One of them was non-inferiority, one of them is superiority. And as such, any argument any of us might say, well, maybe we can do just durvalumab, why do we need the tremelimumab, is incorrect. We clearly, based on the biology we just showed, and based on that evidence independent of any other, clearly the durvalumab plus one single dose of tremelimumab is very critical for those patients to get to that 1/3 of them alive at 3 years. By the way, the benefit was noted in all patient groups. We can see over here very critically that there was benefit for everybody. You can argue, the women, however, doesn't seem that did well. To be fair, this was an extremely small number of samples and of cases, and we would not really make too much of value to that. For the Hep C, interestingly, when we did correct for two disequilibrium in the demographics, which were the ALBI score as well as extrahepatic spread, it actually improved to 0.79. So know that you still have the benefit for Hep C, which I know could be very important for Egypt. I can assure you that, and you can see it in the updated New England publication we just spoke about. Progression-free survival. Of course, progression-free survival here would not matter. Actually, not only in the Himalaya, but in any immunotherapy, because after all, the effect is rather long-term. And as you can see, there was no separation between two arms. We've seen it in other studies like the Ambrave 150 as well. But if anything here, the most important I would like to pay attention to is truly the median progression survival was better than the one that we know about historically. And more importantly, it clearly shows here that there was at least 50% of the patients that were able to be treated beyond the one cycle of therapy. Responses, there were CRs. It's something new to us in HCC to hear. 3.1% complete response in T300 plus D in the one cycle dose of tremelimumab plus durvalumab. Partial response 17%, and if anything, the disease control rate altogether of about 60%. But remember, this number is dependent also on stable disease, which is a well-known things that happen in sorafenib. That's why we see it also in sorafenib. But I would like to pay attention to this medium time to response. Despite that it needs time to prime T cells, remember, we have some T cells already there, ready to kind of like, do their action against any invasion of the human body, being infection or cancer. And that's why the median time to response was only 2 months. Wow, 2 months you get already benefit from the T300 plus D. This is what I just spoke about a little bit earlier, but now that we have the data of the Himalaya, please remember that anti-drug antibody in regard to atezolizumab occur in about 50%. Actually, in the study itself, in the AMBERIF 150 was about 30%, while as you can see to the other extreme, pembrolizumab and durvalumab, barely about 1.5%. Very important note, because it clearly can impact in regard to benefit from those therapies, which clearly can influence atezolizumab, while it really barely apparent on the durvalumab and pembrolizumab. Safety and tolerability in regard to 300 plus D, we can see over here that yes, of course, we had adverse events. The grade 3 and 4 treatment-related adverse events were interestingly lower than what we see in sorafenib, 25% versus 36%. And at the same time, there were deaths, but thankfully they were not related to anything related to the treatment, but all they were related, sadly, to the disease itself. Treatment-related hepatic and hemorrhage enzyme events, these are important because of the immunotherapy. Yes, they were noticed, but as we can see, they were really not highly appreciable. Barely 7% for the grade 3 or more for T300 for hepatic events, which really were limited. At the same time, hemorrhage. And remember, in that study, we did not scope anybody, and there were only 0.5% events of hemorrhage in the study, and nobody died from any bleeding from any varices. Immune-mediated adverse events. So of course, here I'll show the data only for the two arms that have immunotherapy, i.e. T300 plus D and durvalumab. And as you can see, yes, of course they can occur, but thankfully not to any extreme extent. Probably we saw some hepatic event 4%, diarrhea 3%, dermatitis, pancreatitis about 1% to 1.8%, and then insufficiency 0.3%. So all in all, rather very well tolerated therapy. As such, I conclude the Himalaya study was the large phase 3 trial that included global heterogeneous population representative of patients of unresectable HCC all over the world without any exception. The single prime dose of tremelimumab plus regular interval durvalumab doses, what we call T300 plus D or the STRIDE, significantly improved survival, 16.4 months versus 13.8. And more importantly, the landmark analysis at 36 months or 3 years showed 30.7% survival. Overall survival for durvalumab monotherapy was non-inferior to sorafenib with a favorable benefit-risk profile. As such, this trial, T300 plus D and durvalumab monotherapy have management safety profile with really low grade 3 and 4 treatment-related adverse events. And no question, they represent new treatment option for patients with unresectable HCC. We're waiting for the FDA approval, and we are anticipating it hopefully to hear about it soon, now that all the data is out. As we said, complete data resulted in the New England Journal of Medicine evidence. I would like here to thank all the investigators. I will note that we had really a representation from literally all over the world. I have to really make note here, and this is a wish and a hope and a request for all of us to work very hard to ensure that Egypt is represented in those studies in the future. We know that some new future study will represent Egypt, but we need to work very hard to ensure that this presence is always there. Still, nonetheless, we had 30% of the patients with hepatitis C, which represent Egypt as well. I thank you very much, and I'll here pass it back to the chair. Thank you for your attention.
Elegant talk, Professor Hassan. Really, it was a very effective for us for just information for this type of trial. I am Dr. Walid Hamid. I'm professor of tropical medicine in James University. I will introduce our panelists, Professor Ahmed Zaid, Professor of Hematology and Internal Medicine, Alexandria University, Professor Ashraf El-Beredi, Professor of Tropical Medicine in Shams University. And Tropical Medicine, we said always it's gastroenterology and hepatology. Professor Wael Abdelrazik, Professor of Hepatology and Gastroenterology, National Liver Institute, Munafia University, and Professor Dr. Khalid Karim, Professor of Oncology, and for the first time we put oncology just to be with us in our data. Okay. Okay, so let's begin with Dr. Ahmed Zaid.
Thank you, Professor Hassan, for your elegant presentation, and congratulations for the Himalaya study. Now it is approved as the T300D as a first-line therapy in Europe and in USA. But I have a question regarding the exclusion criteria in your study. You have excluded patients with main trunk portal vein thrombosis. My question is, why did you exclude these patients? And if you confront patients with main trunk portal vein thrombosis, will you give them this combination, or will you prefer to give sorafenib?
Sure. Oh, thank you so much for this question. And if anything, please, we have to remember that this is the V4 main trunk portal vein thrombosis, which, as we all know, and respectfully, many of you are in hepatology and gastroenterology, know very well that unfortunately this sadly imply that liver functionality will not be really up to par in regard to giving systemic therapy. So ironically, I'm not even sure these patients will be eligible anyway, i.e. the enhancement of the thrombosis will cause an increase in bilirubin, reduction in albumin, which of course will influence Sharpe score, which we need to be score A to begin with. So these patients are sadly rather more ill at V4, BV4, that probably will not be eligible for systemic therapy anyway to begin with. There was no specific concern beside that that will say that we're worried about anything related to the checkpoint inhibitors per se. Very important to remember that on the other hand, the exception can occur, but there will be really kind of like a transition between V3, V4. But in general, the V4 will not be eligible for systemic therapy anyway.
Thank you, Professor Hassan, for this informative talk, and congratulations again for your publication. I'm asking about the hepatitis B reactivation in patients with hepatitis B virus. As you know, that atezolizumab is one of the agents which carries very high risk for hepatitis B reactivation, and we should start preemptive therapy, antiviral therapy of hepatitis B virus, irrespective of DNA level. Did you encounter or have you encountered any hepatitis B reactivation with the stride regimen? And if so, how did you manage this? Also, in the same setting, have you started preemptive treatment for those patients with anti-hepatitis B virus treatment or not?
Oh, thank you very much. That's a great point. So no doubt, I totally agree that for the hepatitis B, always very important to really treat the hepatitis B. This is like really a very important reminder for all of us. I know that proudly you all as gastroenterologists will do it. Sadly, we always have to remind our colleague in oncology to make sure that they're well aware of checking for hepatitis B to ensure that we treat it accordingly. However, interestingly, the Hep C is a totally different story, because in the Hep C, as we said, the cat is out of the bag already, and the damage in the liver already has occurred. And as such, checking for it, yes, maybe. Treating for it is not necessarily correct. And I know we can debate this for a long time. In the study, we for sure did require Hep B treatment for patients with Hep B, but for the Hep C treatment, there was no requirement for the treatment, and generally people were not treated to begin with because already they have the cancer.
So you started treatment, preemptive treatment for hepatitis B before treatment, right?
That's correct. If patient happen to be not on treatment yet and they have Hep B PCR quantitative, which really would require treatment, for sure, we did start that for sure.
And those patients without hepatitis B DNA, undetected DNA, the surface antigen positive and undetected hepatitis B DNA, have you started them with antiviral hepatitis B?
So for the patient who has a PCR which was negative or less than the 10, which is a standard everywhere, no, they were left alone without any therapy. There was no requirement to treat the Hep B if the Hep B is not really active. Please remember, and I think I like very much your question because this is like really was the main concern back 10 years ago when we started working with AstraZeneca and before that with MedImmune, which is now with AstraZeneca, on the concern about if we reactivate the virus. And we start going a little bit overboard. We start for the hepatitis D, hepatitis B, but at the moment we really have a comfortable zone to really realize that if a Hep B patient is having active disease, we'll definitely treat. If, however, they don't have active disease, we'll just monitor and we'll follow accordingly.
Thank you.
Sure.
Thank you for the elegant talk and congratulations for the excellent study. I have some commendations. I commend your inclusion of viral and non-viral patients, especially B 30%, C 30%, and 40% non-viral etiology of cirrhosis. This was an excellent idea. And I commend also the intention to treat analysis, the use of intention to treat analysis in the study. I would like to ask about the screening for esophageal viruses prior to starting the combination of TREME plus Durva. Thank you.
Thank you so much, and thanks for your notes. Dr. Ryan, can you please repeat what was the question? I didn't hear the last part.
I would like to ask about the indication of screening for esophageal viruses prior to starting TREME plus Durva.
Sure, absolutely. Thanks so much for that question. So first, I would like to comment on what you said in the beginning, which is quite important in regard to the variation of the etiologies that we had in the disease in the study. And we're really proud that we had representation for all the different etiologies. And interestingly, yes, patient with Hep B might pan a little bit better improvement in regard to outcome with hazards that was close to 0.66, followed by the Hep C and followed by the NASH. But however, it's a very important message for all of us. Everybody does benefit from the therapy. Now, you can now imagine why it's unfair to compare studies, because the outcome of the atezolizumab plus bevacizumab was really very much Hep B heavy. And that's why it's unfair to say, oh, 16 is less than 19 or 19 is more than 16. This is not really the point. The point is we have to look at the etiologies and we have to really look accordingly what is the representation distribution of the patients so we can treat accordingly. With this said, we bring in the other point, which is the varices. As you know, historically, actually I started here in New York, like not that far from where I am, at Sinai, in regard to bevacizumab, a single agent, and people died. This is published in JCO, and if anything, there was death related to esophageal varices. And one important point here is we need to all remember, despite Child-Pugh A, yes, we can say comfortably that less likely to get varices. Well, guess what? They can. And that's why it's very important. If anybody decides to give atezolizumab plus bevacizumab, they really got to do the endoscopy. Now, with this said, the endoscopy can be very challenging to read. As we all know, maybe in Egypt, you will do way better than other places because you have transplant experience. And at the same time, you really have a lot of hepatologists because sometimes you don't want to underread a varix because as such, you can put the patient or subject patient to a bleed. On the other hand, you don't want to overread the varix because you'll probably prevent them from getting a certain therapy like what we're talking about is bevacizumab. Interestingly, however, what we are very happy about with the Himalaya is that because we're really doing dual immunotherapy, there's no chemotherapy here, there's no biologic therapy, there's no anti-angiogenic therapy, there's no VEGF, there's no TKI, it's simply all immunotherapy. we really don't feel there's any concern for doing any HIV/VC screening. And patients, as long as they're child PUA and eligible for therapy, this will be enough.
Dr. Ghassan, I'm a professor of clinical oncology, so I'm the one who will get to the critical issues a little bit. So first is a comment and a salute for the recruit number of patients. In comparison to Embrave 150, this is by far, as you have said, and I'm backing you up, it's the largest HCC study with immuno or targeted therapy. And the way the expedited approval and the presence or the appearance of the Tecentriq or the atezolizumab on the NCCN guidelines was far much faster with far less number of patients. So with the Himalaya, you are building a lot of issues to debate and a lot of knowledge after having the subgroup analysis. This is my comment and first question. Any of your subgroup analysis right now, after having all of these large data, have shown which is the best patient to be offered such drug? Because as you know, we are having a lot of survivors of HCV in Egypt after the national campaign we had. So are those patients best eligible, or there is another subgroup you are recommending to start with if you are starting to go on your footsteps?
Well, thanks so much. And by the way, thanks for being on the panel. You're like, you're my supporter here. So thank you so much.
Anytime, sir.
No, but by all means, you're right. And I totally agree. We're very delighted, very excited that we're able to really represent a big study that represent all the different etiologies. And no doubt that the subgroup analysis that we have seen, as I showed it, really shows the value of the therapy for all the subgroups. And we know very well that the Hep B patients might fare a little bit better, but it does not mean the others don't. And that's really what's important, is not to really think about if it's Hep B and I'll treat with the therapy, and if it's not Hep B, I'll treat with something else. Absolutely not. Actually, this is more important statement for what we all were excited about last year. If you recall, in Nature, Dr. Pfister and colleagues data in regard to the non-viral, non-benefit from checkpoint inhibitors. The exercise that was done in that paper, which is a very valuable paper, to be fair, was an exercise of a certain perspective or analysis to see how the data pan out. And if anything, Dr. Pfister and colleagues did not intend to tell us, hey, by the way, don't use it. Actually, to kind of carry the argument, the CD8 cells that are exhausted CD8 that he mentioned were not even defined. Actually, in the paper, if you look at it, he even said, like, we're not sure which cells are they. And funny enough, because these are the same CD8 cells that actually activate Hep B. So as such, I would say that we, yes, have subgroup analyses, but I would say, yes, we need to look at the etiologies, but at the same time, the therapy should be applying for everybody. Interestingly, a very big invitation for all of you, and this is something that we worked with some of you beforehand on, is to ensure that we try to look into the tumor immune microenvironment. Because no doubt that, for example, for a patient in Egypt, futuristically, it's not going to be guesswork. We'll try this and see what happens. No, we're going to come to a point where, because of certain ramifications of the Hep C status, we'll be able to say, that's it. Your therapy is going to be tremelimumab plus durvalumab, and without any doubt, you'll benefit from it. I think we're getting there. It's an invitation for all of you to work with us on this, because we already are doing it proudly with the group in France. We're doing it with the group in Korea. We're doing it now, starting to do it with the group in India, and also are doing it with our group in Hawaii, who's working on all the Pacific islands in the Pacific Ocean.
Actually, the intention of my question was for the benefit of the friends in AstraZeneca, because when we are presenting such an expensive regimen to the government, asking for endorsement or asking to start a study, we would like to start with the best option patient to show case what is the best result expected from them. So to make the argument for the cost benefit for those patients, that was my intention about the question. I'm sorry. I know it is beneficial for all of the groups and subgroups, but for this hepatitis C survival, I think we would need to emphasize the effect of the drug. That was my intention. Thank you.
Oh, thank you very much. I totally agree with you. And we have to remember that this is where our work together will kind of like ensure that we get the approval necessary for those therapies. Because after all, and thankfully, alhamdulillah, in Egypt, we did not put a price or value for the human being. In other words, we really do everything we can within the confine of what the government can cover for that purpose. And the only government, as you know, that really put the pricing is the United Kingdom, the UK. Short of that, we always try our best within the confine of what the economy can help. But of course, this and with other inputs, hopefully we'll get the approval in Egypt soon, inshallah.
Dr. Ghassan, what about the duration of therapy for your combination? And if failure happened, what will be the second line of treatment?
Excellent question. Thank you so much again. So 2 points which are important. One of them I will hold off on discussing, but I'll mention it, but I will not be able to show data, but because, and I explain. Interestingly, what about after the single dose of tremelimumab and patient on durvalumab, and we feel like things are not really going that well? Can we throw in another dose of tremelimumab? Interestingly, on the study, we did permit that, up to the discretion of the investigator. And there were 70 patients that did receive actually booster effect of tremelimumab. We don't have data about telling what this, and to be fair, it's only 70 patients, so it's not enough data per se. But would I say that in real life, let's say I have all the drugs and there is a concern about, I'm not sure what's going on, maybe I'm a little bit worried, can I give another anti-CTLA-4 only as a booster effect to really keep the car going with the durvalumab? Of course I would. With this said, as a second-line therapy, after this, at the moment, we have to depend on what's available in the actual market. And no doubt that because patients did not get yet exposure, if they get durvalumab, tremelimumab, and they did not get exposure to any of the tyrosine kinase inhibitor, by all means, this will make sense. We kind of like have been going on and favoring the lenvatinib simply because it has more potency and more effectiveness than others. And if you recall, back in 2020, 2 years ago, in February 2020, it was the last meeting that I did in person, which was for the transplant group, the TAC that happened in Utah. I spoke about something called line -1, i.e., we are not going to take away the options of first-line therapy and jump onto second-line therapy if we start, for example, with durvalumab, tremelimumab. In other words, we'll do line -1 as being durvalumab, tremelimumab, and still will benefit from lenvatinib first-line therapy before, for example, we move to cabozantinib, etc. So that's really the current regimen sequences that we are thinking of.
Professor Ghassan, I want to ask you a question again. Does it sound a promising idea to add TKI for this stride regimen to enhance the survival and by another mechanism of action against the tumor?
Sure. Thanks so much again. I kind of alluded to that, and I'm happy you asked the question again, because as I already mentioned, I'm using the checkpoint inhibitors as a scaffold, or like as a buildup of a building as it comes up. But what you dress it or cover it with can be those different therapies you're talking about. I.e., your question is, can I have patients on durvalumab, tremelimumab? I even try to really throw in another tremelimumab dose and still ultimately patient progress, because sadly, yes, they can progress. Can I, for example, consider pembrolizumab plus lenvatinib based on the LEAP-02 study, or at least now the phase 2 trial? Of course we can, because simply what you're doing is you're keeping a checkpoint inhibitor and simply you're just adding something else to it, which is totally appropriate and fair.
Another question, please, Dr. Hassan, regarding TACE and systemic treatment. We have some patients that may be in the gray zone, and you may decide to give them a chance of TACE as a superior option than systemic therapy, or to give them a systemic therapy. My question is about combination. did you try to combine immune therapy with TACE in comparison to immune therapy alone?
That's an excellent question. So, as we all know, we did try with TKIs, and I think the SPACE study, the TACE2 study, the ECOG 1208, and many other studies did not really show any benefit for adding sorafenib to TACE. So definitely there was an interest in regard to immunotherapy plus TACE. And I think the EMERALD studies of AstraZeneca, and there's EMERALD-3 that I'm proudly co-chairing all over the world, will be coming soon. So we will see how this will pan out. However, within that context, I'd like to bring a very important point, which is who are those patients? Because as you said, subject of debate. I like to quote here Dr. Kudo from Japan, because he came with the up to 7 criteria that used in transplant. And as we all know, it is the number of lesions in the liver, let's say, for example, 4, so number 4. And then on top of that, the size of the large lesions in the liver, let's say 4 centimeters, so 4. So 4 plus 4 equal 8, which is more than 7. Interestingly, when they did a study comparing the chemoembolization to systemic therapy, patients on systemic therapy fare way better than they did on the chemoembolization. So I would say that disease management team, tumor board are very critical for those studies to make sure that we offer the patient with the best possibility. However, in the future, can we see that a checkpoint inhibitor plus TACE can be beneficial? Yes, we can. With this said, interestingly, we have to think about it this way. Remember, originally, we were thinking about how can we move BCLC-B to C, i.e. can we add something to BCLC-B therapy to make it even better? But the reason the Kudo work can work, and it will apply, for example, for what we're going to hopefully discover with the EMERALD studies, is can we make a BCLC-C benefit from BCLC-B therapy? i.e. patients with more advanced disease, give them local treatment with embolization, by the same time make sure they have immunotherapy traveling through their body, like, for example, with durvalumab, tremelimumab. Time will tell, we just have to wait for the data.
And another point that have been addressed by the fellow panelists is the bleeding. I remember well when the first presentation of Embrave 150 with the long use of PEV, you remember that the bleeding was far much than we thought it would be. So would you think that in a short period of time it will prevail that the safety profile of the combination of T300 plus D is better than the Embrave, especially for those who will continue on BEV for longer time?
So you bring a very important point, and I think you're right. Actually, I've been working with with other colleagues in regard to real-world evidence in regard to the bleeding, and I think you're right. It's probably a little bit more concerned than we think of this. And I wish the study for the Embrave 150 was a little bit more clear about like who are those patients, because they said simply just as per regular standards, whatever it is, local standards. On the other hand, yes, there's a concern about like the exposure to the bevacizumab. However, I please urge you here, and if you remember, I was asked that even during GIS on the first presentation of the Himalaya. Would I say that, oh, if a patient is risk of bleed, that's why I give them the durvalumab, and if they are no risk of bleed, I'll give the atezolizumab? Absolutely not. Because over here, I want you to really read the data a little bit in a broader scale. Here, we're talking about a combination of immunotherapy that really has a potential for 1/3 patient alive at 3 years, and at the same time without any of the risks that we're talking about. So it is really a totally novel approach that, yes, compare favorably when we look at the different etiologies and we get it calculated. Think about it this way. If we're to really do the Embrave 150 with the same demographics as the Himalaya, probably will not fare as good, because it will have only 30% of the Hep B. On the other hand, if we do the Himalaya with the same demographics as the Embrave 150, it's going to do better. So that's why don't compare the two studies, but look at the global scale about the double checkpoint inhibitors, no risk of bleeding, and same more importantly, a prolonged benefit for 3-year survival, 30% at 3 years.
would you kindly comment on the treatment-induced antibodies, anti-Durva?
Yeah, thank you very much. That's a great point. I know that we don't talk much about it, but ironically, the FDA was the first to really bring it up, because at that time, when the package insert, I know none of us look at package insert, but if you have free time, you can look. You'll notice that actually the anti-drug antibody was brought into the atezolizumab, and they specifically say that please note that if a patient has anti-drug antibody, patients will not benefit from the therapy as claimed to by the study. Interestingly, it remained quiet, but to give credit, actually, the investigators of the AMREV 150 ultimately, and last year at AACR in April, they presented the data of the anti-drug antibody. They showed actually that 30% of the patient had anti-drug antibody. And it's very important here to remember that 30% was tested for, but we cannot test in real life. We don't have a test that's available commercially. At the same time, we can't even predict who's going to have them. And ultimately, they showed that actually, if a patient had anti-drug antibody, i.e. the 30% that had anti-drug antibody, the hazard ratio worsened all the way to 0.96, rendering that whole thing of atezolizumab, bevacizumab, add the endoscopy, etc., is equal or as good as sorafenib. And now, I personally would say that at this point in time, because we don't have more ability to look into the anti-drug antibody and see who does it or does not have it, and same time, can we test it or not test it for it? But I think we have a moral obligation to at least bring the discussion with the patient. I think we have to tell the patients, if we give atezolizumab plus bevacizumab, by the way, you have a 30% chance you will not benefit from that therapy the way I'm telling you about it. And I cannot tell if you're going to be one of those or not. And then now it depends. I really want to play risk or not. And it depends on the character. But I would say at least we're obligated to bring it up with the patients.
Let me add something to what you have been saying, especially when the friends here mentioned the portal vein thrombosis or the total portal vein thrombosis in trunk. I personally have been fortunate to collaborate with Professor Dr. Abdelati Hamid, Professor Dr. Gamal Asmat, to do stereotactic radiosurgery for the portal vein, aiming at palliation for recanalization. And we actually have presented our abstract a week ago in World GI in Barcelona. 60% of our patients actually showed partial recanalization. For those patients, and for the motivated one of them, because many of them started to argue, would we bridge it for doing transplant, or can we offer such a patient, after improving the general condition, the pain, the enzymes, and the alpha-fetoprotein dropped with recanalization of portal vein, can we offer them the Himalaya protocol, or you won't recommend something like that?
Well, you can think about it two ways, but I would say that ultimately the patients with portal vein thrombosis, if they happen to have still appropriate liver performance, I would say, as I mentioned a little bit earlier, it become a little bit right at the edge between what we call V3 and V4. And to be fair, none of us really know how to calculate like V3 or V4. So that's why I would just kind of probably say, yes, it's an option that can be open as long as the child plus score A.
Regarding autoimmune disease, Dr. Ghassan, is it absolute contraindication to use immune therapy in patients with autoimmune disease, or you can use this therapy in some patients, for example, with mild disease, because unfortunately we may face some patients that have no other options?
That's a great question. Thank you so much. No, it's not an absolute contraindication. In other words, give an example. Always make sure that if there's an autoimmune disease, involve the gastroenterologist if it was related to for example, ulcerative colitis, involve the endocrinologist if it's related to something endocrinology, etc. More importantly, as an example, if you have ulcerative colitis that has been really very well under control, it does not really limit the patient from getting checkpoint inhibitors. It's simply talk to the different experts, make sure you are on page, make sure you agree on a plan, and of course, continue to monitor the patient correctly.
What's the risk behind this therapy in some patients with severe autoimmune disease? Is it the risk of flare of their autoimmune disease or any other comorbidity?
Sure. Of course, no, it's a flare of the autoimmune disease. And of course, it can be really have serious consequences because as we all know, when the immune therapy unleash the immune system in our body, it can unleash it anywhere. And the last thing you want to hear, for example, God forbids, like a Guillain-Barré happening in the brain because of autoimmune disease.
Professor Ghassan, in your trial, you have patients with BCLC stage B without portal vein thrombosis. Of those patients achieved complete response, and this complete response continued with them. Could we offer them liver transplantation? However, we all know that those patients are taking immune therapy are at risk for graft rejection after liver transplantation. I want to hear from your insights, please.
Sure. No, that's a great question as well. So, number one, we have very clear evidence that after transplant, giving checkpoint inhibitors is not a good idea. Actually, there was a study, and you might recall, I spoke about that at AASLD back in 2019 or 18 in Washington, and we kind of clearly said that no, because there were deaths actually in a study that was done at Mayo Clinic. On the other hand, pre-transplant, do checkpoint inhibitors, to be fair, there's no full clarity on this. It's something that really we have to think of. And I would say that if there is at least a certain period of time and the recovery from the checkpoint inhibitors effect and the whole system for pre-transplant evaluation is appropriately justified, I would not really say it's a limitation, but definitely it would be nice to see some more data on that.
Yes, you recommend that those patients, we could offer them liver transplantation after a period of time from discontinuation of immune check inhibitors, right?
Correct.
Thank you.
And related to the same point, which is complete response. What do you do after complete response? Do you follow your patient only with contrast-enhanced imaging, and for how long? And for those patients, did they show recurrence thereafter or not? The last question related to complete response is, how do you explain that complete response in your study is only 3.7%, while in IMBRAV is about 8%?
Sure. Well, number one, if a patient has complete response, the first thing you do is you go and walk with the patient and kneel, and you'll enjoy it and celebrate it. And number two is, of course, you just continue to monitor. Usually our standard will be every 3 months a CAT scan, and we'll definitely keep monitoring at least for 5 years. And number three is, in regard to the comparison, again, this is what I urged all of us, including myself, we should not compare the data. And if you ask me what's different between 4 and 8, I have no idea. And in other words, if you tell me, for example, it was 100% complete response versus 5, I'll say, yeah, maybe let's talk. But we're still talking about limited complete response, which tell you ultimately those therapies have a benefit. They are very valuable, but of course, it's an opening for us to do more. But by all means, I would not really try to undermine the complete response on the Himalaya. I think it's still present. We definitely have evidence of it.
Thank you, Dr. Hassan. I will just ask you a very small question, and then we'll wait you for case presentation. My question was, unfortunately, we always have child B much more than child A. So in your future plan, do you have support of this type of patient in your T300?
That's a great question. Thank you so much, actually. If anything, the child PUB is a very complex category of the cirrhosis. Let's kind of like just look into the analysis of it. Interestingly, as we all know, and you guys are experts, I had a lot of discussion with you before, and I like very much the clear understanding of what really evolved in regard to liver functionality. A child PUA, it's a long straight line, flying here from New York all the way to Cairo, turn around the world, and still it's a long line and straight. And then B is a little bit of a curve, and C is a shoot. And interestingly, the patient child PUB, because of that curved nature, some of them are really closer to that long line, like B7, and some of them, like B8, B9, are closer to the shoot, which is child PUC. Interestingly, always there has been a push to really involve child PUB. But erroneously, we call child PUB everybody, well, truly we're referring probably, or at least we tested child PUB 7. Can I say that comfortably I can treat a B7 patient with the therapy if really things are within the appropriate confine? Yes, I can, because as you know, magically, any of us can make a B7 A6 or A6 B7. It's very easy to do. On the other hand, for a robust B8, B9, I would say sadly we don't have any therapy at the moment for that purpose. I can tell you, between parentheses, we're working on this, but we don't have any data yet to tell you. For the moment, unfortunately, no therapy for B and B9.
So that's our project with Cairo, and in the next, your future plan, inshallah. Okay?
Inshallah, of course.
Inshallah.
Absolutely.
So we are
Absolutely.
waiting for your case presentation, please. So should you begin your case presentation?
Of course, happy to.
Okay.
So again, thanks so much for the, this was a great discussion. So I'm gonna go ahead and share my screen again. And we're gonna go over a case for the purpose of only bringing some argument discussion, and we'll take it from there. And bear with me one second, I wanna make sure that I'm on the right screen. And I think we are, yeah, you see my screen, a 63-year-old male, correct? Yeah, perfect. So this is 11 years ago, a patient was diagnosed with hepatitis C, treated with interferon on 3 occasions, then treated with ribavirin 7 years ago with a sustained viral response. During workup for a kidney stone, CT scan showed a 7.3 mass in the left lobe of the liver with possible portal vein thrombosis. Perfect case, huh? Like, you know, all what we just spoke about, Hep C and with same portal vein thrombosis. So let's see what the story is. So patient, by the way, has some medications at home. I'm sorry, go ahead.
Was he treated only with ribavirin?
Yes, this is what we know so far. So I'm giving you a case, truly, this is a real case, but simply the patient came to us, all of this happened outside. And if anything, patient was on the following medications. And as we heard, there's hepatitis C, of course, got exposure to Hep C beforehand, Child-Pugh score A, some cardiac stenosis, hypertension, nephrolithiasis, never smoker, no alcohol history. Patient with brother with Hep C as well. And at the same time, the brother had laryngeal cancer, and there was carcinoma of non-primary 60 in the more than 60 years of age in the father. So clearly there's some exposure to Hep C in the family. Oh, sorry, I got the wrong data here. The pathology, and this is an important question which I would like to discuss with you as well in regard to yes or no for pathology. Hepatocellular carcinoma, moderate to poorly differentiated, with extensive visceral invasion with trihepatic and extrahepatic tumor thrombus. The hepatic parenchyma was negative, and the ultimate diagnosis was T3BN0 on the resection. And the patient had minimal portal fibrosis and mild chronic hepatitis. So no question that this was resected and appropriately so based on the disease. I unfortunately did not have in time, even though I asked the pathologist to provide the pathology, but nonetheless, we kind of like come to the point of adjuvant therapy. And again, please, I would say that we don't have evidence of any adjuvant therapy so far. We are waiting for the outcome of different studies, among which, as you can see, the Pembro, Nivo, Durva plus Bev versus Durva, and Atezo plus Bev as well. Ultimately, patient did progress, and if anything, there was evident recurrent disease with two new liver lesions. And patient, again, outside of the institution here, got treated with transarterial embolization plus RFA. And of course, the argument here that we're going to bring a little of discussion on is intermediate stage disease. Do you really treat them? And I think you guys asked the question, do we treat them like local therapy, recurrent therapy with systemic disease? That's really the point that we'd like to discuss. So again, I will go back here to say one more time, there was one more biopsy for the recurrence. And if anything, there was clear evidence for the therapy, and ultimately the patient did progress despite an effort for TACE per se. I'm going to stop here for a second, and I'm going to open it for the discussion. And I know there was a question that was brought up already first about the treatment of hepatitis B, and would love to hear that. Any of the experts can please just bring in their thoughts in regard to, even though, as I said, the patient was not treated for that at Memorial, but it would be nice to hear your thoughts in regard to the immunotherapy. I'm sorry, not the
floor
antiviral
and
therapy. I'm sorry, the
panelists, please.
antiviral therapy. Yeah, go ahead.
Okay, so Dr. Khaled, what's your opinion about that? This and combined.
We should think as any other patient, but the MDT is an essential for that long survivor patient with HTV. I think you will guide as gastroenterologist case because the patient have been treated with antiviral and survived for a long time. So for me, it's actually a difficult decision to go.
Yeah.
Is it? Do you think it's in Egypt we do tests first? We don't do rush on lobectomy or partial hepatectomy. We always interventional radiology helping us much more than the surgeon because it's a little bit maybe costly for the patient. So it's sometimes we go for tests instead, but that's the MDT sometimes. So it depends on our MDT decision, and we will go for it. But it's always interventional radiology win. That's the usual also in your part, or the surgeon always win.
I like what you said. Actually, admittedly, no. Usually, we'll go for surgery first, and but you bring a very important point about what about the approach of localizing the therapy per se. I would say that interestingly, we do the surgery, but we do differ not only in the US, but in the Western Hemisphere altogether from the way Japan does it. Because in Japan, they will really take the whole segment, while in the US, we'll just resect the tumor with the surrounding area independent of segments. And this is really come to a little bit of a philosophical perspective about how the disease evolve. Is it by segment or is it just by random in the liver? This is yet to be discovered. And that's why I'm bringing this example, because it can make an argument. If it was a segmental perspective, it will be more surgical, while if it was non-segmental, it could be more of embolization. But again, this is up to debate. But no, we don't do that say the way you do.
Okay. As a hepatologist, I will go also with the taste first. After the section of the first intervention, but I have a question regarding the liver biopsy. If the liver biopsy is not questionable in the first place, why in the recurrence you did liver biopsy?
Yeah, no, that's a great question. To be fair, you're absolutely right. If there was, and again, as I said, this all happened on the outside, but I brought that case because it can bring those debates. Yes, I don't think there was necessity for the second biopsy. Maybe in cancer in general, if you have somebody with recurrence after 4 years, maybe it's worth doing a biopsy because 4 years is a long time. What if something different has happened? But if something happened within the year, you're absolutely right. No need for the repeat biopsy. On the other hand, however, some pathology in the beginning is very critical. I can understand for surgery, no biopsy because we're going for surgery for a curative intent. I can understand for the embolization that you don't do biopsy because you're doing for localized therapy. But when it comes to systemic therapy, with all the implications of it, a biopsy is very critical.
I think biopsy here was done because this patient may not be cirrhotic patient. As I observed in the pathology report, he has chronic hepatitis with mild fibrosis. And here, contrast-enhanced imaging does not work by the LIRAD system because if the liver is not cirrhotic in hep C patient, we have to do biopsy.
I would say so. I totally agree with you. However, I think the point that was just brought up better well is would the biopsy be needed, the fact that the patient already had surgery, which is fair. But I think your point also is well noted in regard to the fact that we have some findings are not suggestive of. And here I would like to bring in the debate about the LIRAD scoring. Because LIRAD, interestingly, will depend on cirrhosis. And as we all know, Cirrhosis, we don't know yet, any of us, to really how to pin it down. We all can claim it's cirrhotic. We can say it based on clinical findings. We can say it based on lab findings. We can base it on radiologic findings, but none of us follow the same route for how to define cirrhosis, because frankly, it was never defined. This is really like became the unanswered question. So that's really why the biopsy is still necessary in that setting.
Okay, thank you, sir. But what about the role of lab as a joint with this type of radiology? Because sometimes we don't do just like CT triphasic and then alpha-fetoprotein. If alpha-fetoprotein is high, so we can combine this as HCC and instead of doing pathology. That's sometimes the way we do it here. So
Yeah,
what
well,
about
some
that?
people do practice that. Some people do practice that, and I'm not questioning that. But however, I bring two important perspectives in that regard. Number one, as we already mentioned, the mere fact that you don't have a full proof of cirrhosis, because even by lab work, cirrhosis is not really to be proven, because alpha-fetoprotein is not a cirrhosis-related tumor marker. Number two, the ALT/AST can be elevated, but not necessarily implies cirrhosis. On the other hand, though, interesting, even in the LIRAD-5, at tumors which are less than 1 centimeter, they probably will give you that we have 90% or more sensitivity and specificity. But interestingly, the minute you drop down to more than 5 centimeter lesion, the sensitivity and specificity drop to 67%. And my question is, and this will happen, this is how the world is. Our patients are more educated. Can any of us stand, for example, God forbid, like in court or something, and say, this is cirrhosis and this is proven HCC based on LIRAD-5? And you might be asked, like, what about those 40% chance it might not have been? And remember, at least 10 to 15% of patients can have combined cholangiocarcinoma plus intrahepatic cholangiocarcinoma plus HCC. So I would say some tissue is very critical, especially when we come to systemic therapy.
I think I want you to hear your opinion about the transarterial deembolization in those patients with portal vein thrombosis. Here in Egypt, we have a great experience with, and it's actually fruitful experience. We have some patients have recanalization after radioembolization. So this patient would begin with the transarterial radioembolization before resection.
That's a great question. So this is kind of like remain a debatable task. Yes, our colleagues as well, and I'm well aware of your probably your great work in regard to embolizing patients with PVT. We do some of the same, but however, I would say now with the advent of the novel therapies, like we just spoke on the Himalaya study and the durvalumab plus tremelimumab, and with the criteria of more than up to 7 criteria, we have to really be a little bit thoughtful about making sure that everybody is aware of and is on the table to offer the patient best therapy. Because I tell you, funny enough, that I had a patient coming in one time and I said, well, embolization is a pro thing. I'll send you to the colleagues for doing embolization. He said, no. I didn't come for you for this. I came for those new immunotherapies. So patients know what the benefits are. And as such, the nice thing about HCC is that it's a two-way street. It's not only from B to C, but can be from C to B, i.e. I will never rule out the embolization, but know that if the patients are beyond up 7 criteria, considering the systemic therapy first is not a bad idea either.
Okay, continue, please. Okay, thank you.
Sure. So what I'm going to do is actually, the questions are great, and I know we're almost coming to time. But what I'm going to do is I'm going to go back and share my screen one more time, and I'm going to actually jump on directly to, because this is what we were just referring to, directly to the systemic therapy, because ultimately we will kind of, bring in some of that data per se. And I'm going to jump on here. Let me share my screen. I'm going to jump into the up to 7 criteria because this is where we left over. Now, the patient, you recall, we spoke about that got some systemic plus embolization, but ultimately did progress. And we spoke about those studies that are ongoing phase 3 trials and there's more of those as well. These are definitely I'm in favor of, and we'll see what they're going to lead to and what outcome we'll get. And I'm very happy and proud to see that Egypt is part of the Emerald study as well. With this said, ultimately patient progressed, and now patient, as you can see, really is still a little bit stuck into the local therapy, but ultimately got into this. And this is the data from the Dr. Kudo in Japan on the up to 7 criteria, which already I explained during the lecture. But as you can see over here, the improvement is that the comparison was at the time lenvatinib versus TACE, 37.9 months for lenvatinib versus 21 months for the TACE. This is something to think very carefully about in regard to our analysis about how to treat patients best. So with this said, we come up to the systemic therapy. As I said, now if the tumor is exceeding up 7 criteria, tumor larger than 5 centimeter, if there's multiple nodular tumors that could occur, and this patient there was, poorly differentiated or undifferentiated CC, and no objective response to 2 consecutive days, maybe all of those can be a requirement to get into the systemic therapy. And that's exactly what happened ultimately. We have here the only thing that I will carry on, and you remember the Optimus study that looked into the repeated days, and you can see over here that no doubt the benefit declines over time, and if anything, no doubt that delaying systemic therapy can be a little bit of an issue as well. And this is really where we are in regard to systemic therapy altogether. So as you can see, we have the sorafenib that we started with back in 2007. Then we had a lot of efforts you can see in the gray that really are all negative. So it's not like we were doing nothing. Then we come to lenvatinib. We then got atezolizumab. And then no doubt we're waiting for the pembrolizumab plus lenvatinib. And on top of that, of course, now we can add on the durvalumab plus tremelimumab. And no doubt in second-line therapy, which was already a question that we were asked, regorafenib with the requirement of prior sorafenib, and nivolumab is out of the market. So please, I urge you not to take it, because actually even the sponsor pulled it out. Pembrolizumab is fully approved. Cabozantinib, no requirements. Ramucirumab, if you should be more than 400. And the Nivo plus IPI, interesting, that is still kind of like in analysis and studies are being complete. But if anything, please do remember, and I think the best person who spoke about that was Dr. Tim Meyer from University College of London, when he showed at ASCO back in 2019, or correction, in 2020, the concern about the adverse events from the repeated IPI in that setting. And of course, we have other drugs that are happening in other parts of the world, like China per se. So the question is now, the patient actually, in our specific case, did receive Pembro plus lenvatinib, because this was available to us at this point in time. And with certain concerns, we decided not to give him anything beside that. And the question is now, if we're still on Pembro lenvatinib, if the patient is to progress, what shall we do? And this is maybe another one that we can talk about in the discussion.
So Dr. Khaled, please.
It will, if we start with something potent like lenvatinib, it will give us a chance to go further as a second line. After pembrolizumab, yes, we are speaking about what's further. So after pembrolizumab, I think we have a chance with the Himalaya if the patient is still in a good shape. Would you think so, sir?
Well, no, this is a great question, and that's the point. It's not necessarily about the Himalaya per se, but you're right. It's a good point. Ironically, I can say, like, why we didn't start with the Himalaya if the Himalaya was available. But you're right. Let's think in reality, the patients on pembrolizumab, Himalaya will ultimately be approved while still patient on pembrolizumab. Would I consider giving him durvalumab after that? Of course, why not? because as we spoke a little bit earlier, the scaffold is already there. I'm simply changing anti-PD-1 to anti-PD-L1, and more importantly, I'm removing the anti-FGF with the lenvatinib, and instead I'm putting anti-CTLA-4 with the tremelimumab. So by all means, it's a very nice thought, and I would say that there's nothing crazy about it.
But I need your opinion as an oncologist, sir. Are all, because this is something, not only the protocols are not to be compared, I think not all anti-PD-L1 are to be compared also. Do you think that?
That's a great point. So no doubt we showed at least one perspective regarding the anti-drug antibody, but you're absolutely right. There could be other differentiation. I'll give an example, for example, of the enhancement of the Fc gamma 3, that some of them will do it more than others. We spoke, for example, about the potency of the anti-CTLA-4, which is, for example, in the example of tremelimumab, is 3 times more potent than CD28 itself. So no doubt, yes, they are not necessarily all the same. And ultimately, I think we will come to a custom-made therapy for patients in the future, but understand we're not there yet, and we have to depend on the one-size-fits-all until then.
So if such patients, and are going before Himalaya, what other medication you would recommend? If you don't put a Himalaya, what atezolizumab, or what do you think in your mind?
Yeah. So if let's assume Himalaya is not there or didn't even exist, or as you said, like not available or approved per se, I think a pembrolizumab is appropriate. I would say atezolizumab could be considered. It will be a little bit giving a little bit the concern about the issue of the anti-drug antibody and the bleed, but there's something to at least be thoughtful of and talk about. And ironically, what about even giving lenvatinib alone and then on progression give pembrolizumab? At least we can do this in the US because pembrolizumab is fully approved. So I would say that yes, you can be in the imaginative in regard to make the most benefit to give a TKI at least once and a checkpoint inhibitors at least once. But this is the beauty of the Himalaya. It will kind of like will give you that cloud of checkpoint inhibitors right from the top and from the start.
Okay. Any question, Floor? Okay, Doctor.
Dr. Ghassan, you addressed the up to 7 criteria from Japan, especially which is beneficial in, as I mentioned before, the patients in the gray zone between TACE and systemic treatment. Do you work by this up to 7 in all centers in USA? Of course, oncologists will prefer this up to 7, but I think it is not taken as a decision maker in many centers. What's your opinion at first? Do you work by it in all centers? Or on
no, that's a great point. No, thank you so much. This is a great point. And no, I would say no, not everybody is even aware of the data. We do our best, not only me, but other colleagues as well, to pass it on. But I have to give credit, at least at Sloan Kettering, for example, our colleagues in interventional radiology and in surgery already are kind of like well aware of the up to 7 criteria. And especially I give credit for our colleagues in interventional radiology are definitely adapting by it and are really going by that direction to even sometimes or many times they will send patients for systemic therapy because beyond up to 7 criteria. It needs a little bit of further work. And to be fair, always is a kind of challenge. When you do certain data in one part of the world, it really will not translate until you do it in the other parts of the world. So a certain revision of the up to 7 criteria globally, something that, for example, we can do together, Egypt and the US, will be probably a good idea.
Okay, thank you, sir. Okay, will you continue the case, please? Yeah,
actually, no, the case is done. If anything, the patient ultimately, as we just mentioned, got pembro plus lenvatinib. Yeah, the patient is well, exactly, thankfully. That's so far so good.
That's
Can I ask
nice.
last question? Or,
okay, Dr. Ashraf, he wants to ask you a question.
One last question, please, Dr. Ghassan, Professor Ghassan. If patients on double agents like pembrolizumab and lenvatinib, and patients has good response, and developed a serious adverse events grade 3 to 4. Would we stop one of them and continue with others, or would we stop both of them?
Sure. That's a great point. So, interestingly, it can be erroneously misperceived that, one or two, it doesn't matter. And for example, I hear this sometimes, I don't have time to do an endoscopy, or there's no availability for endoscopy, or the patient doesn't want to endoscopy, I'll do atezo alone. Not a good idea. That's on one hand. On the other hand, let's say now we're on the therapy, and let's say patient is, for example, now getting side effects. By definition, the combination should be understood as one item, and as such, patient need to change therapy. I would say this is with diverse events. On the other hand, if it was for a certain progression, this is the beauty. For the first time we're seeing it, and we'll probably need to, until we experiment it, all of us in real life, is can we boost the effect again? For example, as we just gave the example of the durvaltrami, where you simply have some progression, you throw in one more dose of trami with the hope that things will get better again.
Thank you.
Thank you, Dr. Hassan.
Sure.
Anything else? Thank you, Dr. Hassan, for your elegant talk, really. And now the mic was Dr. Gamal. تفضل دكتور جمال.
For this, thank you very much for this fruitful presentation, and I wish to thank the panelists for a fruitful discussion, and of course AstraZeneca give us a big chance to discuss more and more about our major problem of hepatocellular carcinoma nowadays. As I said, we started systemic therapy in our centers for the National Committee for Control of Viral Hepatitis. Mainly, most of our patients till now are using sorafenib. We have about 1,000 patients, and this is, as I mentioned before, data coming from the National Committee for Control of Viral Hepatitis from Muhammad Abdullah, the manager of this program. And we know that the multiple kinase inhibitor working in this by preventing the kinase, by inhibiting the kinase. And we now heard from Professor Ghassan Abu Alfa about immunotherapy and the checkpoint inhibitors and how to use this checkpoint inhibitor, whether PD-1, PD-L1, or CTLA-4. And it is now our era for management of hepatocellular carcinoma by these drugs, whether immunotherapy or the multiple kinase inhibitors. The immunotherapy also give us a big chance by combining immune checkpoint inhibitor with existing therapies for hepatocellular carcinoma, as we discussed, with the resection, with the radiofrequency, with TACE, even with other multiple kinase inhibitor, with the radiation stereotactic, Dr. Khalid, as you mentioned. We have to look for that also and to have our data from that for cytotoxic agents. So we are now opening a lot of area for research, and as we mentioned, immunotherapy is going in every stage, whether in early stage, intermediate stage, advanced stage, or as a second line therapy. The take-home message is that hepatocellular carcinoma is a common tumor, unfortunately with poor median survival rate, especially in Egypt. Immunotherapy for HCC is still in its infancy compared to other tumors where they used this immunotherapy in a well-established form. We are waiting for more and more. We are now striding into a new era of anti-cancer treatment where immunotherapy will soon become the cornerstone for our treatment. And also we have to look for the potentially immune adverse reactions. And I have to mention that we have In the UCHID, the United Conference for Hepatogastroenterology and Infectious Disease Conference, we have our website and we have the expert consensus statement in this website. And also I have to mention that this session will be present on the also on the website of the UCHID for anyone who wants to see this fruitful discussion and this fruitful presentation of Professor Ghassan and our distinguished panelists. And thank you very much. And I wish to invite all of you for the next UCHID conference on 22nd of September this year on this hotel. And thank you very much for your time and for your joining us. Thank you very much.
Thank you very much, Dr. Jamal. And I would like again to thank you all. Shukran jazilan. I would like to thank you all. Thank you, Dr. Jamal, for the invitation. Thank you, Dr. Walid, for moderating. And of course, a great pleasure to have the great discussion with my dear colleague, Dr. Ahmed, Dr. Ashraf, Dr. Khalid, Dr. Wael. And thank you for all the audience. And inshallah, next time in person, Dr. Jamal.
Inshallah.
That will be our pleasure. Sir. That will be our pleasure. Thank you very much for your time and for your advice. And next year, you should be with us, inshallah.
Okay. All right. Thank you, everybody.
Bye-bye. Bye.